Like I said, what I'm going to go over is, and I already started going through some of these questions previously on for our Unit 3 exam, which is next week. So I'm going to go ahead and go through. Remember, we're doing lung anatomy and physiology, and then kidney anatomy and physiology. Okay. So starting off with the lung, I asked this a couple weeks ago, and I said, which of the following terms would you use to describe the movement of air into the lungs? What would we call that? So not ventilation, inhalation, or inspiration. Okay, so inhalation or inspiration. What would be movement of air out of the lungs? Yeah, expiration or exhalation. And what would it be called for the general term for movement of air into and out of the lungs? And that's what Adrian said, ventilation. Ventilation is just movement in and out, okay? Is desperation a term that we would use with the respiratory system? Yeah, yeah, sometimes, no. But desperation is a distractor term, okay? What is the role of the dust cell? So these are found in the lungs. What do the dust cells do? Okay, but yes, they pick up debris. So what type of, so they pick up debris. What else would they be looking for? So debris, yes. What are dust cells? What type of cells are they? Good. So what else do macrophages do other than clean up debris? Okay, well, that's debris. Clean up dead cells. What else are macrophages associated with? Think about the last unit. There you go. So pathogens. So remember, macrophages are essential for they're potent antigen presenting cells. So they're going to clear out or remove pathogens and debris. Yes. Yes. So the alveolar macrophages, also known as the type 3 pneumocytes, also known as dust cells. Yep. Where do the tertiary bronchi go? What part of the lung or what region of the lung do the tertiary bronchi go? Segments. Good. Where do the secondary bronchi go? Lobes. And where do the primary bronchi go? Into the lung. Right. So into the right and left lung. So it goes right, left lung. Then once we're in the right or left lung, lobes, and then segments. All right, I want to know if this is part of the upper respiratory tract, lower respiratory tract, or neither. Nasal cavities. Esophagus. Neither. Neither. What's the esophagus part of? Part of your digestive system. Has nothing to do with your respiratory system. Can air go into the esophagus? Sure, and then you get burps. What about the pharynx? What about the nasopharynx? Oropharynx? Laryngopharynx? Still upper. All upper. What about the lungs? Yeah, that's part of the lower respiratory tract. All right, once we get into the lungs, now we're into the lower respiratory tract. Okay. Okay. So trachea is still considered part of the upper respiratory tract. Trachea is, it depends on the text, but we'll go ahead and say trachea is lower. Because I think the last, what we would consider upper is like, where is your glottis? When you get like laryngitis, so your larynx is pretty much the last, what's considered upper respiratory, and then we get into lower respiratory. So that the trachea has stuff going on, but it doesn't have a whole lot going on. All right. Atmospheric pressure. What does atmospheric pressure contribute to as far as breathing is concerned, or the respiratory system? What are we doing with atmospheric pressure in regards to your respiratory or your lungs? Okay, so what are we doing in order to inhale and exhale in regards to atmospheric pressure? Good. Okay, right. So we're going to change and adapt the volume of the lungs, right? The thoracic cavity. So if I want to bring air in, I have to increase volume, which causes a decrease in pressure. And if that pressure is lower than atmospheric pressure, then air should come into the lungs. This becomes a challenge when you're at a high altitude, you're in a very high altitude, like you're in an airplane, or you're in space, because you can't get your lung pressure lower than the low pressure that's in elevation. The same thing happens when you go very deep, right? When you go very deep into the water, the pressure increases significantly, and so it's crushing. And that's what, things can get crushed the deeper things go. So the role of atmospheric pressure is just in ventilation, in the ability to get air into and out of the lungs. Your atmospheric pressure is playing a role in that. So I have two types of intercostal muscles. I have internal intercostal muscles and external intercostal muscles. When the internal intercostal muscles contract, they bring the ribs down. So what part of respiration would we expect to see the rib cage come down? Would you see that in inhalation or exhalation? Good, exhalation. And when in doubt, when you're reading through these, I should be hearing breathe in, breathe out, feel it, okay? So the external respiration causes your ribs, or your external intercostals cause your rib cage to elevate, which is associated with inhalation. The internal intercostals cause your rib cage to depress, which is associated with exhalation. During exhalation, does the diaphragm move up or down during exhalation? It moves up. Good. What happens to the thoracic cavity volume during exhalation? Does it increase or decrease? Decrease, which coincides with the diaphragm moving up, right? That's the thing that's always like tricky, and you got to make sure you're looking at that, because the diaphragm moves up during exhalation and it contracts down during inhalation. That's the thing that's like kind of weird about it, because it's a weird muscle. Okay, when you inhale, it collapses down, right? Or when it contracts, it goes down, and when you exhale, it comes back up. We used to have lung models in like a little plastic, like they could cut off like a soda bottle, like a 2-liter bottle, put like a balloon on the bottom and two kind of balloons on the top, and you can manipulate it and see the air kind of moving in and out. And I was surprised we didn't have those models out. Maybe something happened to them. All right. Oxygen. How is most of oxygen transported in the blood? How is it connected? What's it connected to, or is it just free floating in the plasma? Hemoglobin. Yeah, it's bound to hemoglobin. That's the main thing. So like 90, 93, 97, 95. I think it depends on the book, but greater than 95% is bound to hemoglobin in the red blood cell. Some of it is dissolved in the plasma. If I give you a statement, oxygen is not transported by blood, it's a false statement. Okay, good. Okay. Yeah. Oxygen most certainly is transported by the blood. That's the main thing that's transported in the blood is oxygen. Yeah.
Might be a dumb question, but I'm gonna ask it anyway. So a red blood cell is composed of hemoglobin plus what else? Or is
So
it like all hemoglobins just like together?
So your red blood cell still has cellular components like any other cell. The one thing that it's missing is the nucleus. So
So where's
hemoglobin's like, no, it's on the inside of the red blood cell. Yeah, it's one of the reasons why you don't have a nucleus is because hemoglobin takes up so much space in the red blood cell. So if you had a nucleus there, it would be your red blood cell would be too big to navigate around your bloodstream. Okay. So you probably still have like mitochondria. You have like, they don't really talk about it. You probably still have all the other rudimentary structures that are there in a typical cell, but you definitely don't have a nucleus, which means you don't have DNA, RNA in order to make proteins, which is why the red blood cells begin to break down. So, but there's still components there. There's still things that keep it functioning, but it doesn't have a nucleus. But the hemoglobin's right there in when they depict it, it's right there in the middle of the red blood cell, but where it actually is might be dependent. It's a good question. Not a bad one at all. All right, so listen to the intro to this question. When inspiratory muscles contract, so think inspiration, what happens to alveolar volumes? Do they increase or decrease? So inspiratory muscles contract. What's happening to the alveolar volumes? Yeah, the alveolar volume is going to increase. Okay. I am. It's the computer does it now, so we're all, yeah, yep, we're good. So the alveolar volumes increase. What happens to alveolar pressure? Decreases. Good. So the reverse of that, if I said expiratory muscles contract, which might not be the best term, because technically your diaphragm relaxes, but your internal intercostals contract. So you could still use that term. Then we would see the alveolar volumes decrease, and then the alveolar pressure increase. Okay. So remember how we did our lung volumes and capacities? Now you should know this, but and we'll just see what you know before I give you the answer choices. But which volume prevents the alveoli from collapsing? You got it. Yep. The residual volume, the air that's always in there, right? The air that's always in there helps to keep the alveoli open. So good job. Yeah, the residual volume. That's one of the reasons why you can't get rid of it. A lot of it is because it's equal to atmospheric pressure. So you can't move it out because you have to be able to move against atmospheric pressure in order to get it out, and you can't. So it's trapped in there. And you want it to be trapped in there. Temporarily, at least. It gets recycled. All right. Here's some, I'm just going to ask you some statements, and you just indicate true or false. If we increase the diameter of an airway, will that increase the resistance to airflow? False. Okay, that would actually decrease, right? So what would we call that if we increase the diameter of an airway? What does that refer to as? What's being dilated? Yeah. So it's called bronchial dilation. Okay. Vasodilation, vasoconstriction is the blood vessels, right? Okay. And we do talk about both those things, right? So kidneys, we talk a lot more about blood vessels, but in the lungs, we're talking about the bronchial circulation or the bronchioles. All right, true or false? Air moves from an area of low pressure to an area of high pressure. Yeah, we can't move low to high, but we can move high to low. So a way to remember that is if there's a boulder at the bottom of a mountain and I push it, will it go up spontaneously? It will not. But if I push it up top of a mountain, it'll go down, right? Because we have a high to low relationship. That's more about potential energy and kinetic energy, but you get the concept.
So it does not move.
It does move high to low. It does not move low to high. Nothing moves low to high unless there's ATP, and gases don't move low to high. I don't know that they can. If I increase lung volumes, will that cause a decrease in lung pressure? So it's almost like we're hearing that question over and over again. And if I decrease the diameter of an airway, will that decrease the resistance to airflow? No, it's going to increase. So again, that's another inverse relationship. Okay. It's the same as the first. So I said, instead of increasing diameter, I said decreasing diameter. Decreasing diameter decreases airflow. All right, we had a couple of terms that talked about where gas exchange occurs. So what do we call the gas exchange that occurs between the bloodstream and alveoli? See if you remember this. Look that one up. That was in your notes. We talked about it. So there's a term associated with gas exchange between the alveoli and the blood. And then there's a term associated with gas exchange between the blood and the tissues. So look that up. Once you see it, you'll be like, oh, that's obvious, but look that up. So we talked about hemoglobin and how it's bound, oxygen and how it's bound to hemoglobin. How is CO2 transported in the blood? How is it primarily transported? Yes, but very, very little bit. So what is the most carbon? How is it transported in blood? So a little bit on hemoglobin, but like less than 10%. Okay. Diffused in what? Okay. What specific part of blood is it dissolved in? And then what specific ion is it contained in? Yeah, just bicarbonate. Yeah. So it's going to transport in blood, predominantly in the plasma, but it's not free floating in the plasma. You don't have bubbling CO2 hanging out in the plasma. CO2 combines with water to form carbonic acid, and then the carbonic acid dissociates into hydrogen ions and bicarbonate ions. And so CO2 hangs out in the bicarbonate. Good. So we have three types of pneumocytes. Which ones are the cube-shaped ones that secrete surfactant? Type 1, type 2, or type 3? Good, type 2. Yeah, type 2 are also known as your surfactant cells. And then type 1, that the reason they're type 1 is because they're the most abundant. That's your simple squamous. That's your most common type. And then type 3, we already mentioned, were the dust cells. This was not in our notes, but it is definitely in your book. You should know the difference between the Haldane effect and the Bohr effect. Okay, the Haldane effect, Haldane, and Bohr, Bohr. So which of the following epithelia lines the trachea? I'll give you a clue. It's my favorite one. No, that's not my favorite one. You're throwing in some microbiology in there. Pseudomonas. Yeah, pseudostratified, ciliated, columnar with goblet cells. Yeah. That's exactly the word for word. Pseudostratified, ciliated, columnar epithelium with goblet cells. In Spanish, pseudostratified, ciliated, columnar epithelium con goblet cells. Con. That's something. Trachea, predominantly the trachea. Where do we find, since it was mentioned, and that is another epithelial type to know, but not until the next chapter, where do we find transitional epithelium? In the urinary bladder. Good. Okay, so this is something that we touched on, but we didn't really, I didn't feel like I hit on it really hard during the lecture component. So the major gas that's going to affect respiration is CO2. CO2 has more of an effect on how your respiratory rate like increases or decreases, increased depth, decreased depth, more so than oxygen. Oxygen really doesn't have much of an effect on your respiratory rate. It's more about what CO2 is. And the reason is because the receptors, the predominant receptors for CO2 are going to be located along the brainstem, specifically the pons and the medulla. And what happens is when they detect that the hydrogen levels are, hydrogen ion levels or the acidity is too acidic or the pH is too low, they're going to respond by causing an increase in respiratory rate. Okay. And that increase in respiratory rate has everything to do with CO2. Well, CO2 is a major driver in that. There are other things that lead to the acidity of the blood outside of CO2 by itself, but it's CO2 that's going to dictate your increase in respiration, your decrease in respiration. So if CO2 is high, we're going to expect to see an increase in respiratory rate. And when CO2 is low, we're going to expect to see a decrease in respiratory rate. Okay. If oxygen is high, really not going to have an effect because that's not necessarily a bad thing. You just have to utilize that oxygen or it just kind of continues to circulate if it's trapped in the blood, but usually it's going to be utilized. So you don't usually have a problem with too much oxygen. Too little oxygen is going to cause some problems and may affect respiratory rate, but CO2 is the major driver to your respiratory rate. What is the cue to increase the number of erythrocytes? What triggers erythrocytes? Right, so that's the hormone, right? Erythropoietin, secreted by the kidneys. And then what is the trigger to make more red blood cells? Low, not low blood pressure, good, but low something. What do red blood cells carry? Yeah, so when oxygen is low, okay? When oxygen is low, erythropoietin is released. It's your kidney that detects oxygen. The reason that's important too is because when you know that the kidney is monitoring oxygen and your brainstem is monitoring CO2, it helps you to kind of connect and remember which is the central chemoreceptors along the brain and spinal cord and which are the peripheral chemoreceptors, like the kidney, blood vessels. And then even though the peripheral chemoreceptors are also monitoring CO2 levels and pH and things like that, they respond to the oxygen, low oxygen, okay? All right, what is the largest cartilage in the larynx? Commonly associated with or called the Adam's apple. Thyroid cartilage, not your trachea. Is the specific term, yeah. Yeah, so specifically on the thyroid cartilage, it's called the laryngeal prominence. How many lobes are in the left lung? How many are in the right? Does oxygen have an effect on the respiratory rate and depth of breathing? What if oxygen's really high? Yep. No effect. Okay. If oxygen is really low, yes. Okay. Potentially. But if oxygen is really high, for what we know right now, we're just going to say no. Okay. Because what do they do when someone's on an oxygen tank? They're trying to force feed oxygen in there. Hopefully, some of it gets into their lung or into their bloodstream, right? Because a lot of times when they have like emphysema or whatever other reason, they gotta have to use artificial air or not, it's not artificial, but they have to use a pressure gradient to bring in. What else do you see on people's oxygen tanks?
PSI.
Yeah, PSI. What's that big warning thing that's right next to their oxygen tanks? Yeah, flammable. And what else do you see those people who have a history of emphysema? Yeah. Yep. I remember being at the dentist one time and looking outside, and there's this little old lady with her mask off, hopefully the tank off. She's sitting there smoking, and I was just like, oh man.
We had to do a service project, and I was helping out this one woman trying to move to the assisted facility home. She was a smoker.
Yeah.
Had oxygen tanks all over her house.
Yep.
House. I wasn't looking for it, going, hey, you're something on the color in the wall here, you just paint your house. You know, like, you cracks them all, went down to the basement, saw her there. She's there in the garage, door open, smoke with her oxygen still in it.
Painting. Yeah.
Gas,
Yeah, fair. Yeah, gas tanks open.
This stuff outside.
So we talked about CO2. We talked about oxygen. What do hydrogen ions, what do you think that will do if they're increased to your respiratory rate? Will it increase respiration, decrease respiration, or do you think it'll have no effect? Good. Now, do you understand why? Decreasing. Yeah. So pH drops. But what, when hydrogen ions are high, what does that tell you, or what can you assume about CO2 levels? Good. Yeah. Right. Because how do we make hydrogen ions based off of that one piece of chemistry I've asked you to know? Hydrogen or CO2 plus water creates carbonic acid, which dissociates into hydrogen ions and bicarbonate ions, right? So there's a direct relationship in the amount of CO2 and the amount of hydrogens. When we get into the next chapter 26 for the next, I'm going to show you how that differs. And we're going to talk about the differences between respiratory and metabolic acidosis. We can actually look at blood gas levels and differentiate between those two. But for right now, CO2 is high, hydrogen ions are high. Respiratory rate is also going to be increased because we want to get rid of the CO2. And if we get rid of CO2, we're going to drop hydrogen ion concentrations, which causes the pH to come back up to normal range. I mentioned this a little bit earlier, but what part of the body is going to be the regulator, or where we would find the respiratory centers that regulate respiration? Where do you think that is? Okay, good. Not hypothalamus, but yes, brainstem. What parts of the brainstem? Medulla and pons. Yeah. Yeah, specifically the medulla and pons. So not the kidney and the liver, not the heart and lungs, and not the nose and mouth. Okay. What do I need in order to get, so now we're moving into kidney. What do we need to get in order to produce angiotensin II? What do I need? Okay, I need renin. Keep going, because that's early on in that pathway,
which converts the
which converts angiotensinogen to angiotensin 1. Converting enzyme. And then, okay, so what two things do I need to make angiotensin 2? What were the last two things you said, Mike? Or any other? Yeah. So you need angiotensin 1 and you need the angiotensin converting enzyme in order to make angiotensin 2. Now, this is one of those chicken egg questions, except there's an answer to this. You know, the question like what came first, the chicken or the egg? But there is an answer to this. So if I have angiotensin 1, can I make angiotensin 2 by itself? Right. So what is the limiting step? It's the enzyme. So if I ask you, how do I make angiotensin 2? And I give you renin, angiotensinogen, angiotensin 1, and angiotensin converting enzyme, the best answer is you need angiotensin converting enzyme. If you don't have the converting enzyme, angiotensin 1 cannot become angiotensin 2, at least not that we know of at this level of the class. You know anything about enzymes, technically anything can happen, or anything can happen. It just may take a lot more energy or time for that to happen. Does anyone remember where is angiotensin converting enzyme found? Previous chapter. In the lungs. Yeah, in the capillaries of the lungs. One of the reasons why I like the renin angiotensin aldosterone mechanism is it's one of the few examples where we have like a total body involvement, right? We get low blood pressure, which typically you think of cardiovascular system for your blood pressure, but that's being detected by the kidney. Then the kidney secretes an enzyme that's going to interact with another an inactive protein that was created by the liver. Then that protein that was created is going to interact in the capillaries of the lungs, and then we're going to get an effect on the blood vessels. We're going to get aldosterone released from the adrenal cortex, and we're going to get ADH released from the posterior pituitary. So it's just kind of neat how like all that, I say neat because it's neat to me. I know you guys are like, this is not neat. Just tell me what I need to know for the exam. I understand. But it's neat to me because we can, you see how the whole body is involved with these different mechanisms. I think it's neat. Yes. Renin comes from the kidney. Yeah. Yep. Angiotensinogen comes from the kidney. Yeah. I mean the liver. I'm sorry. Angiotensinogen comes from the liver. Right. So angiotensin 1 is only going to be produced when renin is released. And that's only going to be released in the bloodstream. So just to kind of qualify what you said, the liver only makes angiotensinogen. It doesn't make angiotensin 1. But what is angiotensin 1? It's the active form of angiotensinogen. So yes, it does, but right. All right. I'm in the renal corpuscle, okay, which consists of Bowman's capsule and the glomerulus. What do we call the cells that are lining the glomerulus? Good guess. I'll help you out. They have foot-like extensions. Okay, it's a good one to look up. Yep, perfect. Podocytes. Yep. Yep. So remember when we talked about filtration at the glomerulus, you have the glomerular capsule. It's covering up the glomerulus, and sitting right on top of the glomerulus are these things called podocytes. And they create these little fenestrated slits that again help to keep the solids from going into the nephron, right? Because we don't want big proteins, we don't want cells going into the thing, into the nephron. Of the glomerulus. Glomerulus is just capillaries, yes.
So can you repeat the question from the beginning?
So I said, what are the cells that are typically associated with the Bowman's capsule area that surround the glomerulus. Those are the podocytes. Yeah, the glomerulus is capillaries, yes. Aldosterone. So going back to our renin-angiotensin-aldosterone. What does aldosterone control the reabsorption of? There are times go ahead. Thank you. Okay. I was going to say, there are times I wake up and I'm like, I'm really making an impact. People are hearing this. I've said it at least 15 times over the course of several chapters. They know aldosterone is associated with sodium and water reabsorption. Today's not that day. All right. So aldosterone, sodium, link it. Okay. Here's the other link I asked you to know. If sodium's being reabsorbed, what's being secreted? Potassium, because they move opposite one another. Okay. Sodium's reabsorbed, potassium secreted. Good. What other hormone that we talked about, or peptide or protein, regulates sodium in the kidney? So we talked about sodium reabsorption. What causes sodium secretion? What causes sodium secretion? So aldosterone causes sodium reabsorption, but what causes sodium secretion? It's not ADH. Good guess. Because ADH only has to do with what? Water, right? So it has nothing to do with sodium. So what's the other one that literally has sodium in its name, but it's not sodium? It uses the sodium abbreviation that's on the periodic table. Good. Atrial, natriuretic, hormone, peptide. It goes protein. It has a couple different names. So a peptide and a hormone and a protein are all the same thing. If you don't know this already, hormones are proteins. Proteins are proteins, hormones are proteins, enzymes are proteins. It's all proteins, okay? It's just that how they function, that's what differentiates if it's an enzyme or hormone. Okay.
So that makes sodium get reabsorbed.
Sodium secreted, right? Because the only thing that's going to reabsorb sodium is aldosterone, or increase sodium reabsorption.
Where does that's from the heart.
The atrium, yep, exactly. So what happens is the right atrium will detect if the blood pressure is too high. That's how it lowers blood pressure, by lowering blood volume. Okay. Remember, aldosterone is being secreted because the kidney detects low blood pressure. And then in order to increase blood pressure, we reabsorb sodium. Because what follows sodium?
Calcium.
Well, yes, but what's sodium's buddy? Chloride. Yeah. So sodium and chloride kind of go hand in hand, because that helps you to remember, so wherever sodium goes, chloride follows, and water follows the salt. Okay. If you eat a lot of salty foods, what do you feel like doing? Drinking, right? Drinking something. Okay. Pretzels are making me thirsty, right? Okay. Quote Kramer. I might come up to it later on, I might not, but what causes, so we talked about the two things that regulate sodium are aldosterone and ANH, or natriuretic hormone, or atrial natriuretic hormone. What regulates calcium that we talked about at the level of the kidney? So calcitonin is a calcium regulator, but not at the level of the kidney that we've discussed. So what's the opposite of calcitonin? You can look that one up. All right. We have two types of nephrons. Okay. Which one is the most abundant type of nephron?
The shorter one. is called
Thank you. That's good.
not juxtillary, not juxtamedullary, so the other one.
Okay. Anyone help her out? What are the other ones called? Where are all the nephron or all the renal corpuscles located? In the cortex. So what do you think we would call the most abundant type of nephron located in the cortex? Cortical. Yeah, so the most numerous or the most abundant type of nephron are cortical nephrons. And then you have juxtamedullary nephrons that make the concentrated urine. Thank you. Parathyroid hormone, you're right. Calcitonin may have an effect on the kidney, but we didn't talk about it, so I can't remember if it does or doesn't. Calcitonin,
I'm doing creatinine.
yeah, so calcitonin increases calcium absorption at the bone. So when the blood calcium levels are too high, we need to store it. That's why I was saying I don't think that it causes us to get rid of it at the kidney, but it might. So I don't know that though. All right. Remember we talked about different types of pressures? So if I say colloidal pressure, is that a pulling pressure or a pushing pressure? Good. The pulling pressure. Okay. What's pulling? What's pulling is the proteins and cells, depending on what we're talking about. So if I say blood colloidal osmotic pressure, I'm talking about your red blood cells and your albumin, amongst other proteins in the blood that are trying to keep the fluid in the blood vessel. Okay. If I say blood or glomerular capillary pressure, would that be a pulling or a pushing pressure? Good. So any hydrostatic pressure, usually indicated as just, if it doesn't have the word colloidal in it and it mentions pressure, it's usually a pushing pressure. So blood pressure is a pushing pressure. Okay. It's a hydrostatic pressure. Tissue also has pressures, like your glomerular capsule. It's resisting blood from getting into it. It actually creates a physical barrier that keeps the blood from coming into it. All right. So what we're going to do is